Hi guys, welcome back to Doctor's Desk. Today we are going to discuss about the one of the last chapters of critical care series, which is chapter 318, nervous system disorders in critical care. So we're going to see approach to comatose patients, then encephalopathic patients. We are going to see about monitoring of intracranial pressure and other nervous system disorders. So I have gone through the whole chapter, and I have made a PPT on it. So let's dive into it. So coming to the pathophysiology of brain edema and ischemic cascade, there are two types of edema called vasogenic and cytotoxic. Vasogenic is due to blood-brain barrier breakdown, and cytotoxic is due to cellular swelling. So there's something called ischemic cascade, which explains why early intervention matters. So ischemia promotes release of excitatory amino acids, especially glutamate, which leads to calcium influx and causing free radicals. Then this leads to lipid peroxidation, causing apoptosis and necrosis. This is the chemistry of apoptosis and necrosis. Coming to cerebral perfusion and autoregulation. Cerebral perfusion pressure means mean arterial pressure minus intracranial pressure. It's a driving force of brain blood flow. Basically, in healthy brain, autoregulation keeps flow steady, and mean arterial pressure range roughly around 50 to 150 mmHg. After severe injury, this autoregulation is often impaired. That means, like when there is hypotension, it produces ischemia. When there is excessive BP, it raises the ICP. So that's what the autoregulation impairs during brain injury. So initial approach to a severe brain dysfunction patient. So when patient arrives with encephalopathic or comatose, you have to act fast by securing the airway when GCS is less than or equal to 8. Then we have to oxygenate to 94 to 98 percentile and also avoid hyperoxia, and we have to check bedside glucose to treat hypoglycemia immediately. Then we have to control seizures if present, and rapidly we have to draw ABG to check the basic biochem. Then we have to take a complete blood count, site toxicology, and also we have to send for ECG. Then early neurology consult and consider EEG if a suspicion of seizures. Coming to ICP, which is intracranial pressure monitoring. So there are three devices here in the picture where you can see the ventriculostomy, brain tissue oxygen probe, and fiber optic interparenchymal ICP monitoring. These are the three devices used to measure ICP. So ventriculostomy is the gold standard. It provides accurate ICP measurement and lets you drain CCF to immediately. But it has higher bleeding and infection risk, whereas in intraparenchymal monitors it is easier to place, but and also have low infection risk, and it also continuously record ICP, but you can't drain CSF from intraparenchymal ICP monitor. Then brain tissue oxygen probes, it's an optional adjunct. Then stepwise treatment of elevated ICP includes, first we have to come up with the simple maneuvers, like we have to elevate the head around 30 degrees of the bed to drain the venous. Then drain CSF via ventriculostomy if in place. Then consider osmotherapy, mannitol around 25 to 100 grams, Q fourth hourly as needed, or you can also use hypertonic saline. 30 ml, 23.4% NaCl bolus. Then glucocorticoids, dexamethasone 4 gram 6-hourly for vasogenic edema from tumor or abscess. Then we have to sedate, example morphine, propofol or midazolam, and also add neuromuscular uh, blockades if paralysis if necessary. Then hyperventilation, then PRES therapy. Then we have to consider second tier therapies for refractory elevated ICP like decompressive craniectomy and high dose barbiturate therapy or hypothermia to 33 degrees Celsius. Then, yeah, then intracranial pressure, the practical ventilator and hemodynamic adjustments. Ventilation, avoid hypoxia and hypercapnia. Then PEP caution, avoid large increases uh, that impairs venous return. Then maintain euvolemia, use vasopressors to target MAP for CPP. Then I avoid hypotonic fluids. Coming to the disease part, or hypoxic-ischemic brain injury. So the mechanism is global ischemia leads to selective vulnerability of hippocampus or cortex. Early CT often normal, so MRI diffusion weighted uh, can be can sensitive is sensitive for pattern of injury. Then EEG is generalized slowing, burst suppression or non-reactive. And targeted temperature management is the mainstay of treatment around 32 to 36 degrees Celsius. And avoid fever, keep them in normoglycemia. Goal is less than 10 mmol per liter. So this is the diffusion weighted magnetic resonance of hypoxemic ischemic brain injury after an cardiac arrest. Next, coming to the seizures. Seizures are often non-conclusive. EEG is indicated for unexplained coma, prolonged encephalopathy, or post-cardiac arrest. It can be seen in these conditions. Then EEG patterns shows generalized slowing, periodic discharges, rhythmic patterns, burst suppressions, and electrographic seizures. Treatment includes IV benzodiazepines, levetiracetam, valproate, phenytoin, and treat continuously if refractory, and also consider continuous EEG monitoring. This is the EEG after cardiac arrest. You can see the burst suppression pattern seen in comatose patient with severe hypoxemic ischemic encephalopathy after cardiac arrest. Coming to osmotic demyelination, um, it occurs due to rapid correction of hyponatremia, pontine or central myelin damage occurs. To avoid this, we have to avoid rapid correction. The presentation shows delayed or acute encephalopathy, dysarthria, dysphagia, quadriparesis, or sometimes locked in. To prevent this, we have to correct the sodium slowly. Next, Wernicke's disease. It's basically due to thiamine deficiency. It has a triad like ophthalmoplegia, ataxia, and confusion. It requires immediate administration of high dose thiamine in a dose of 500 mg per IV. This thiamine should always begin prior to IV glucose solutions and continued 3 times daily for 2 to 3 days. So these glucose infusions may precipitate Wernicke's disease in a previously unaffected patient. So we have to give thiamine, next glucose. Coming to posterior reversible encephalopathy syndrome, um, they have a headache, visual disturbances, seizures, altered mental status, then MRI shows a vasogenic edema in the posterior white matter. So common etiologies like hypertensive encephalopathy, then post-carotid endarterectomy syndrome, preeclampsia or eclampsia, or disorders due to drugs like calcineurin inhibitor toxicity, or chemotherapeutic agent toxicity, then HELP syndrome, hemolytic uremic syndrome. These all are the triggers for posterior reversible encephalopathy. So it is diagnosed by MRI flare T2, which shows posterior symmetric edema. Treatment is supportive, control BP, withdraw of offending drugs, then treat seizures. Most patients improve when the cause is reversed. Then sepsis-associated encephalopathy, it is multifactorial. It occurs in burns, it occurs in chemical toxicities or infection toxicities, which needs a supportive care, and we have to treat the systemic cause also. Many patients with critical illness, sepsis or SIRS develop encephalopathy without an obvious explanation. The cytokine tumor necrosis factor, interleukin, IL-1, IL-2, IL-6 are thought to play a role in this syndrome. Clinical features include hyperreflexia and frontal release signs such as grasp or snout reflex, and myoclonus and astraxis can also be seen. In this patient, S100 beta is a biomarker. So it's a injury biomarker seen in sepsis-associated encephalopathy. So treatment, we have to treat the underlying infection and supportive care must given. Then critical care neuromuscular disorders includes critical illness polyneuropathy, Guillain-Barré syndrome, myasthenia gravis, and botulism. Then critical illness polyneuropathy and critical illness myopathy is diffuse weakness, diffused difficulty in weaning. So they should be checked for EMG, NCS. Then we have to treat by optimizing glycemia and mobilization. Then we have to avoid excessive steroids and neuromuscular blockers. In Guillain-Barré syndrome, ascending weakness, possible respiratory failure also can be seen. Then in these patients, we have to treat with IVIG, plasmapheresis, and monitor FVC for early intubation. In myasthenia gravis, usually patients, these kind of patients presents to ICU in a crisis state where weakness and respiratory failure is seen. Treat with IVIG, plasmapheresis, anticholinesterase, steroids, and consider intubation and ICU care. Botulism, where you can see descending flaccid paralysis, autonomic dysfunction, and early antitoxin supportive ventilation is given. Then neurotoxicities of immune therapies like checkpoint inhibitor related neurotoxicity, which causes encephalitis, seizures, demyelination, immune suppression, which can be treated by high dose steroids and or IVIG. CAR T cell therapy, which causes cytokine release syndrome and immune effector neurotoxicity, which has features of confusion, seizures, and edema. Treat cytokine release syndrome aggressively and manage neurotoxicity with steroids, supportive care, and it's a multidisciplinary approach. Like we have to collaborate hematologist, oncologist, and other specialties. Prognostication, monitoring tools, and rehabilitation. Multimodal prognostication, like a repeated examination, EEG, MRI biomarkers to avoid early withdrawal. Then continuous EEG and advanced monitoring should be done. Then early rehab prevent secondary injury. Then fever control, glycemic control, then prophylaxis for thrombo venous thrombosis, then nutrition should be given. Mobilization should occur in early as after the patient gets cured. So coming to the last slide. So when patient presents to you, you should check for airway status, then imaging results, then check for whether the patient needs ICP or not, then current ICP and CPP targets, then whether you have started osmotherapy, which agent should be used, whether continuous EEG is needed or not, and these kind of clarity saves time and lives. To summarize, the brain is unforgiving but predictable. Know the mechanism, we can treat the injury, and also apply the stepwise ICP algorithm, which I have shown in the previous slide. Uh, and we have to detect and treat the seizures, focus on prevention and rehab. Most of the time, these neurological conditions will mostly end up in a death. Not all the time, they may end up in a survival state. So we have to know the correct mechanism and prevention and injury. We can treat them and we can gain the life back. So thank you. Do subscribe to Doctor's Desk.